Hey, thanks for checking out the quiz on vertigo. Let me teach you one lesson that took me a while to learn is that you have intake diagnoses and you have observation diagnoses. Now, intake diagnoses are when someone comes in with a problem they want you to fix. However, there's some things that are observational diagnoses. This is sometimes when a patient comes in your office and then doesn't realize that you treat the shoulder or the foot. They observe that you do something different, whether it's rack cards, whether it's the patient education video you have in your waiting room, or something you talk about during that actual treatment visit. But there's also another type of diagnosis within that observational diagnosis, and it's when you see a patient get up from a chair, when they get off your table, when they have dizziness, when they roll over after you've treated their neck and you're working on their back. It's important to bring up those different diagnoses because those things help us and help deliver the kind of care that your patient wants and needs. Cervicogenic vertigo and BPPV are one of those diagnoses that I see and I know you see all the time in your practice. The question is, are you going to remain silent or are you going to start treating these things like we should and like we're educated to and able to? There's a lot of times that people are getting insufficient care by looking at the wrong type of problem because it's easy. And I'm not saying treating these things is easy, but it is straightforward as long as we come up with the right diagnosis. So thanks for taking this quiz and let's go over the results. So the first one is, where do we get most of our proprioceptive input? Now, proprioceptive input when it comes to balance, which is what we're looking at most of the time, is due to the eyes. It's looking at the cilia within the semicircular canals. And it's also looking at the actual proprioceptive input from the cervical spine, and that's what we're going to talk about here. Most of the time, it's choice A. It's the occiput through C3, where we get most of our range of motion and most of our proprioception. Question number 2. Don't ever want to see letter B. When you see vertical oscillation of the eyes, that's pathognomonic with an actual central nervous system problem. It doesn't always have to be though. You can have just typical upbeat and downbeat nystagmus with a typical evaluation, and it could be normal. However, this is a red flag in my mind. I'm going to want to refer this one out for future evaluation. Number 3, head fixed body turn test. This is a great test to figure out, do I have BPPV or do I have cervicogenic vertigo? When you hold their head in one position and you just rotate their body, so a head still, and I'm going to rotate my body, I'm not moving the actual head, so I'm not going to be stimulating the cilia, I'm not going to be stimulating the eyes because we're looking forward, I'm only stimulating the cervical proprioceptors, so in this case, be cervicogenic vertigo. Number 4, when we see vertigo due to something bad, meaning it's not the cilia, it's not the eyes, and it's not the neck, this is when we want to consider something more serious or sinister in etiology. So if there's a cerebrovascular problem causing dizziness, that's when we start to see our D's and N's. When patients start to drop those words on you, it's time to refer out, at least for an evaluation, to make sure it's nothing more serious. Number 5, name this test. This is my favorite test because it's really a great sensitive test to figure out, is there something wrong? It doesn't necessarily tell me if there's something wrong with the cilia, with the eyes, or with the neck. It kind of stimulates all of them. So here with letter C, Dix-Hallpike maneuver is the name of this test. It's going to look for all of those things, cervicogenic vertigo and BPPV. 6, cervicogenic vertigo patients require myofascial release and stretching of which muscles? So we always think about the suboccipital muscles, and so do I. Works very well as far as that's where we get most of our proprioceptive input. However, don't forget about the upper trapezius and the SCMs. A lot of times when our patients have that head forward position, those muscles, those ancillary muscles of neck movement are also hypertonic, limiting range of motion. And here's one trick that I use with my patients. I shouldn't say trick, maybe an educational piece, is I'll say that, listen, Sally, one of the things that we have an issue with is when you turn your head 45 degrees to the right and your brain says, hey, Brandon or Sally, turn your head 45 degrees to the right, but it only turns 35 degrees, there's a sensory mismatch in there, and that sensory mismatch is what I'm talking about as far as creating issues with balance and dizziness, leading to these types of symptoms. Finally, number 7, which single procedure leads to resolution of symptoms in up to 70% of BPPV patients? I would love it if cervical mobilization was the #1 thing. However, I will say that when it comes to cervicogenic vertigo, manipulation is key. When you look at Carol Levitt's information, 90.2% resolution of patients with cervicogenic vertigo using manipulation, it just works that well. However, if there is truly a problem in the semicircular canals, well, I'm not going to leave out manipulation. I'm definitely going to be incorporating letter B, Epley's maneuver. This is a great way to shake up those otoliths, get them back down in the ampulla, and make sure that we're getting that person to function properly. When we can do that efficiently and effectively, we can really solve a lot of problems. Now, there is a little bit of confusion on which maneuvers and which evaluations to do for a BPPV. Fortunately, in Chiro, we made it extremely simple. If you go into the condition reference section and you go into BPPV, what you're going to find is a list. And it's going to say if they have posterior canal, if they have anterior canal and horizontal canal BPPV, which are the most common, posterior being the most common. Here's the exact evaluation, meaning Dick's halt pipe for posterior and anterior, and supine roll test for the horizontal. And then here's the actual treatment. So it is recipe format, but that's fine. For this kind of diagnosis, we have to make sure that we're doing the right evaluation for the right diagnosis and giving them the right treatment. It also obviously includes the head fixed body turn test if we determine it's more of a cervicogenic vertigo. So take this quiz, share it with your friends, and also it's okay to get answers wrong. When you get an answer wrong, that's an opportunity to learn, an opportunity to help your patients get well in your practice. I hope this helps.